Welcome back to the Deep Dive.
Glad to be back.
Today we're going deep on managing high cholesterol in adults.
Right into the nitty-gritty.
And to do that, we're going straight to the source, the 2025 Guidelines from the American Association of Clinical Endocrinology.
The AACE.
Yeah, exactly, the AACE.
This guideline is all about nonstatin medications.
So not just statins, but all the other options.
Right, all the drugs that we might use when statins alone aren't enough or aren't a good fit.
And ultimately, what's the goal here?
The goal is to help you prevent those serious cardiovascular problems you hear about, like heart attacks and strokes.
So let's set the stage for our listeners today.
Sure.
What are we specifically zeroing in on? And what are we going to leave out for another deep dive?
Good question.
Because cholesterol is such a big topic, right?
It is.
We can't cover it all.
No, not all in one go.
Yeah, so think of this as like the advanced course in cholesterol management.
That's a great way to put it.
All right, so we're focusing on using non-statin drugs. So we're not going to talk about when to get your cholesterol checked or what those numbers on your lipid panel mean.
We'll save that for another time.
Right? Or even the super important stuff about diet and exercise.
Yes, those are foundational, but we're building on that today.
And we're not going to get deep into statins themselves.
Right, the AACE has separate guidelines for all that.
So we're assuming you've got the basics down.
We are.
So this is really for those situations where the first steps maybe haven't been enough.
Yeah, and even then, even when we are talking about medications,
Right.
it all starts with knowing your risk for what we call ASCVD.
Atherosclerotic cardiovascular disease.
Exactly. That's the buildup of plaque in your arteries.
And that's really the starting point for making any decisions about treatment.
It is. And don't forget, even if you are taking medication, lifestyle changes are still super important for managing your heart health.
Couldn't agree more.
It's a package deal.
All right, so mission for our listeners today, if you choose to accept it,
I like that.
is to come away understanding the main recommendations for using non-statin drugs to manage high cholesterol, all based on the latest science.
The cutting edge.
Exactly. So let's jump right in.
Let's do it.
First thing the guideline tackles is figuring out your risk.
Risk assessment is key.
So recommendation number 1 is all about that.
It stresses the importance of using a validated tool to predict your future risk of ASCVD.
And why is that so important?
Because it helps you and your doctor make those informed decisions together, especially when we're talking about prevention.
Preventing problems before they even start.
Exactly. That's the ideal scenario.
Now, I know a lot of people hear about these extra tests.
Oh, yeah, there are a bunch out there.
Like coronary calcium scans,
Right.
ApoB, LPA.
I've heard of those.
Yeah. So do these guidelines recommend routinely adding those tests to the risk calculation?
Well, that's where it gets interesting.
Oh,
the guideline actually suggests there's limited benefit in broadly adding those measurements to the standard risk calculators.
Really?
Yeah.
I would have thought more information is always better.
You would think so, but the data doesn't really back that up in this case. The experts looked very carefully at how much these extra tests actually improve our ability to predict future heart attacks and strokes. And for most people, the improvement is pretty small.
So walk us through some of the specifics.
Sure. So, for example, when they looked at adding a coronary calcium score, the improvement in prediction was pretty small.
What do you mean by small? Like, what are we talking about here?
Well, the SIC statistic, which is a measure of how well the model predicts risk,
Right.
it only went up by a tiny bit, like less than 0.09 in some cases.
Oh, wow, that is pretty tiny.
It is. And for ApoB levels above a certain point, the increase was even smaller, almost negligible. And for LPA, it was similar, a very small potential improvement.
So basically, even though these tests give you more data,
They do.
it doesn't necessarily mean a huge shift in your overall risk assessment.
Right. The guidelines suggest that these small potential improvements in risk prediction probably don't outweigh the downsides.
And what are the downsides we're talking about?
Well, first, there's the cost of these extra tests.
Right, of course.
And also the potential anxiety that more testing might create for some people.
Yeah, nobody wants more tests if they don't have to.
Exactly. So for most people, the small increase in precision might not be worth it.
That makes sense. Are there any situations, though, where those extra tests might be worth considering?
There are the guideline mentions that for individuals who are found to be at intermediate risk after the standard assessment and who really want a more detailed understanding of their risk and they understand the costs involved, then these additional tests could be considered.
So it's really about personalizing the approach.
It is tailoring it to your individual circumstances and preferences.
Now, are there any cases where those standard risk calculators might not be enough?
Yes, there are. It's important to remember that standard risk calculators might underestimate the risk for individuals with familial hypercholesterolemia.
Okay, and remind us what that is again.
Familial hypercholesterolemia is a genetic condition that leads to very high cholesterol levels, often starting at a young age.
Okay.
In those cases, a different, more comprehensive approach to risk assessment is usually needed.
So you might need to go beyond those standard calculators.
Exactly.
Okay, let's move on to some specific medications.
Let's dive in.
One class of drugs that we hear a lot about are the PCSK9 inhibitors.
They're definitely getting a lot of attention these days.
So what do these guidelines say about when those might be the right choice for you?
So recommendations 2 and 3 focus specifically on evolocumab and alirocumab, which are two types of PCSK9 monoclonal antibodies.
Right.
Now, for adults with high cholesterol who are already on the highest dose of a statin that they can tolerate
Okay.
and who have already had a heart attack or stroke or are at very high risk, but their LDL cholesterol is still below 70 milli-GDL.
So they're already doing a lot to manage their cholesterol,
Right.
but it's still not quite where it needs to be.
Exactly. In those cases, the AACE suggests considering adding either evolocumab or alirocumab to their treatment plan,
Ready?
but this is a conditional recommendation.
Okay,
Meaning the evidence is pretty good, but it's not absolutely definitive.
Gotcha. So it's not a slam dunk, but it's worth considering.
Right.
Now, what about people with high cholesterol who haven't had a heart attack or stroke yet?
So for adults with high cholesterol but no history of ASCVD, meaning they haven't had those major cardiovascular events,
Right.
the AACE suggests against routinely adding evolocumab or alirocumab to their care.
So different advice depending on your history.
Yes, your individual risk factors play a big role here.
Makes sense. Now, can you remind us how these PCSK9 inhibitors actually work to lower cholesterol?
Absolutely. So think of it this way.
Okay.
Your liver cells have these little docking stations for bad cholesterol, which is the LDL-C we're trying to lower.
Like little parking spots.
Exactly. PCSK9 is like a signal in your body that tells the liver to get rid of some of those docking stations.
Oh, so less parking available.
Right. So if you block PCSK9, you have more of those docking stations available to grab and remove that bad cholesterol from your blood.
And that's where the PCSK9 inhibitors come in.
Precisely. There are special proteins called monoclonal antibodies that block that PCSK9 signal.
So they keep those parking spots open.
Exactly. More spots for the bad cholesterol to get out of circulation.
Okay, that's a great analogy. So
Yeah.
what did those big clinical trials show about how well these drugs actually work to prevent heart problems?
So the main evidence for evolocumab comes from a study called Fourier.
4 year.
Yeah, and it showed a small reduction in the risk of having a heart attack
Okay.
and probably a small decrease in stroke risk too, although that decrease might not be super noticeable on an individual level.
Right.
Importantly, though, it didn't show a statistically significant decrease in overall mortality or the need for procedures like stents or bypass surgery.
So it helps, but maybe not as dramatically as we might hope.
Right, the benefits are there, but they're not huge.
Gotcha. And what about alirocumab? What did this study show for that drug?
So the Odyssey Outcomes trial gave us the main data for alirocumab,
All right.
and it also showed a small decrease in heart attack risk,
Okay.
plus very small reductions in problems with blood flow in the legs and overall mortality.
Interesting. So similar to evolocumab, it sounds like.
Yeah, pretty similar. It probably didn't lead to a big enough decrease in stroke risk cardiovascular deaths or the need for those artery opening procedures to be considered clinically meaningful.
So again, some benefit, but not a game changer.
Right.
Are there any other important points about these studies that our listeners should know?
Yes, a few things to keep in mind. Those studies followed people for a relatively short period of time.
Okay.
And there haven't been any head-to-head trials comparing evolocumab and alirocumab directly.
So we don't know for sure which one is better?
Not yet. But some analyses that combine the results of different studies suggest that alirocumab might have a slight edge in reducing the risk of dying overall.
Interesting.
Also, there's a longer-term extension of the evolocumab study,
Okay.
and it didn't find any increased risks of developing diabetes or having a bleeding stroke with long-term use.
That's reassuring.
It is.
Now there's another PCSK9 inhibitor called inclisiran.
Yes, inclisiran.
What's the word on that one?
So recommendation number 4 is all about inclisiran.
Okay.
And basically it says there isn't enough evidence right now to recommend for or against its use in adults with high cholesterol.
Really?
Yeah, so the guideline essentially says we need more data.
Huh. Interesting. Why is that?
Well, even though inclisiran also lowers LDL cholesterol by targeting PCSK9, it works in a slightly different way.
How so?
It's not an antibody like the other two. It's a small piece of genetic material that tells the liver to make less PCSK9 in the first place.
Oh, wow, that's pretty cool.
It is, but the main reason for the lack of a clear recommendation is that we need more large, long-term studies looking at its impact on heart attacks and strokes.
So the studies we have now are promising.
They show it lowers cholesterol, but we need more data on those hard outcomes like heart attacks and strokes.
I see. And what about the dosing schedule for inclisiran? I remember hearing it's only twice a year.
That's right, and that's definitely a potential advantage. It could help people stick to their medication better.
Yeah, that makes sense.
But there are also some potential downsides. The cost can be a barrier,
Of course.
and it also needs to be given by a healthcare professional in a clinic setting.
So not as easy as just popping a pill at home.
Right, and that could create access issues for some people.
So it's a trade-off.
It is.
Convenience versus cost and access.
Exactly.
Are there more studies planned for inclisiran?
Yes. Thankfully, there are some large trials underway like Orion 4 and Victorian 2 Prevent.
And those will?
Those are expected to give us more information about the long-term cardiovascular effects of inclisiran.
So hopefully more answers coming soon.
Hopefully.
All right, let's move on to another medication, bempedoic acid.
Okay, bempedoic acid.
What do these guidelines recommend about when to use that one?
So recommendations 5 and 6 deal with bempedoic acid.
Okay.
Now, for adults with high cholesterol who can't tolerate statins.
So this is specifically for people who have trouble with statins.
Yes, and who have already had a heart attack or stroke or are at high risk for those events.
Okay.
The AACE suggests considering bempedoic acid in addition to their usual treatment.
Another option for those who can't take statins.
Right.
But what about people who can tolerate other cholesterol-lowering drugs and haven't had a heart attack or stroke?
For those individuals, the AACE suggests against routinely using bempedoic acid in addition to their usual care.
So again, different advice depending on your situation.
Exactly.
Now, how does bempedoic acid work to lower cholesterol?
It works by blocking an enzyme in the liver called ATP citratelase.
ATP citratelase.
Yeah, it's a mouthful, but basically this enzyme is involved in making cholesterol.
Okay.
So by blocking it, bempedoic acid reduces cholesterol production.
And that leads to...
That leads to more of those LDL receptors on the liver, which helps clear more bad cholesterol from your blood.
So it's working in a different way than statins.
It is. It works upstream of where statins work in the cholesterol-making pathway.
Interesting. And what have the studies shown about how well it works and how safe it is?
The study showed that bempedoic acid can lead to a small decrease in the risk of heart attacks and problems with blood flow in the legs.
Okay, that's good.
But there was also a moderate increase in the number of people who had to stop taking the medication because of side effects.
Oh, and what were some of those side effects?
Some of the more common ones were gout, gallstones, and tendon rupture.
Those sound pretty serious.
They can be. So a careful discussion with your doctor about the potential benefits and risks is really important.
I imagine, so the guideline really emphasizes shared decision-making here, right?
It does. You and your doctor need to weigh the potential benefits of bempedoic acid against those potential harms before starting it.
And it's important to note that the evidence for its use in preventing first-time heart attacks or strokes is limited.
Very limited.
Okay, let's move on to triglycerides.
Okay, triglycerides, those are another type of fat in your blood.
And the guideline has several recommendations about using EPA and DHA to manage high triglyceride levels.
It does. Recommendations 7 through 10 are all about that.
So let's break those down.
Okay.
For adults with triglyceride levels between 150 and 499 mg/dL.
So moderately high triglycerides.
Yeah, and who also have ASCVD or at increased risk for it.
Meaning they've had a heart attack or stroke or are at high risk for those events.
Right. The AACE suggests using EPA, specifically a prescription form called icosapent ethyl, or IPE,
Right.
in addition to taking a statin.
But this is a conditional recommendation with a lower level of certainty in the evidence?
Okay, so EPA might be helpful, but the evidence isn't as strong as for some other things we've talked about.
Exactly.
Now, what about when triglyceride levels are really high, 500 mg/dL or higher?
So for severe hypertriglyceridemia,
Right.
the guideline says there isn't enough evidence to make a clear recommendation for or against using EPA.
So more research is needed.
Yeah.
And what about using EPA and DHA together like you see in a lot of fish oil supplements?
So for those folks with moderately high triglycerides between 150 and 499 mg/dL, and who have ASCVD or are at increased risk,
Right.
the AACE actually suggests against using EPA plus DHA in addition to a statin.
Really?
Yeah, this recommendation also has a low level of certainty, but the evidence seems to point in that direction.
Huh. Interesting. And again, for severe hypertriglyceridemia.
There's not enough evidence to recommend for or against the combination.
So it sounds like, for now, EPA alone might be the way to go. And
Right.
even then, the evidence isn't super strong.
That's a fair assessment.
What did the studies show about these different approaches?
Well, the studies on EPA alone suggested that it might not lead to noticeable decreases in overall mortality or stroke risk. However, there was a small decrease in the risk of heart attack.
So some potential benefit there.
Right, and it didn't seem to increase the chances of having to stop the medication because of side effects. But there was a possible increased risk of major bleeding and atrial fibrillation.
So that's something to keep in mind.
Definitely.
What about the studies on EPA and DHA together?
So those studies using doses of 1.8 grams per day or higher suggested that the combination might not decrease the risk of dying, having a heart attack, or a stroke. And it probably doesn't decrease the risk of cardiovascular death or needing those procedures to open up your arteries.
Okay.
What's more concerning is that it probably increases the likelihood of having to stop the medication because of side effects.
And are there any specific side effects that were more common with the combination?
Yes, there's a potential increased risk of atrial fibrillation and major bleeding with the combination.
So it sounds like those potential downsides might outweigh the benefits in a lot of cases.
It's possible, and it's really important to remember that these recommendations are specifically about prescription medications with high doses of EPA or ETA plus DHA.
Not just any old fish oil supplement.
Right, over-the-counter fish oil supplements vary a lot in what they contain and how much.
And they're not regulated the same way as prescription drugs.
Exactly, so it's hard to know what you're actually getting with those.
Good point. And is there anything else to note about EPA and DHA for high triglycerides?
Yes. One more thing, there isn't good data yet on whether either EPA alone or in combination with DHA can help prevent pancreatitis in people with very high triglyceride levels.
Okay, so that's still an open question.
Yes.
Let's talk about another medication that's sometimes used for high triglycerides, niacin.
Niacin.
What does the 2025 guidelines say about that?
So recommendations 11 and 12 are all about niacin. They're pretty clear-cut. The AACE strongly suggests against using niacin in addition to usual care if you have triglyceride levels between 150 and 499 mg/dL and you've already had a heart attack or stroke or are at increased risk for those events.
So a pretty strong stance against niacin there.
It is.
What's the reasoning behind that?
The main reason is that niacin doesn't seem to lower your risk of dying, having a stroke, or needing those procedures to open blocked arteries.
So it doesn't have much benefit.
Right. And on top of that, it's linked to a bunch of side effects.
Oh, and what are some of those?
We're talking about things like flushing, gastrointestinal problems, gout, elevated liver enzymes, muscle pain,
Oh, wow.
and even an increased risk of infections, bleeding, and high blood sugar.
So a pretty long list of potential problems.
It is.
I remember seeing medications that combine niacin with statins. What happened to those?
Those are no longer FDA approved.
Really?
Yeah, they didn't show any added benefit in preventing heart problems, and they actually increased the risk of side effects.
So not a good combination.
Not really, and just like with the omega-3s, there isn't enough data to say whether niacin can help prevent pancreatitis in people with very high triglycerides.
So more research needed there too.
Exactly.
Okay, let's wrap up by talking about LDL cholesterol targets.
Right. What levels should you be aiming for?
The guideline has some recommendations about that, right?
It does. Recommendation number 13 addresses this issue.
And what does it say?
So for adults who are taking medication for high cholesterol and who have already had a heart attack or stroke or are at high risk for those events,
Right.
the AACE suggests an LDL-C target of less than 70 mg/dL.
Okay, so that's the magic number to aim for.
Well, it's a target to consider, but this is a conditional recommendation, and the certainty of the evidence is low.
Okay, so not set in stone.
Not at all.
Why is it? What does the evidence say about that target?
So reaching that target of less than 70 mg/dL did show a small improvement in the risk of dying from any cause or from cardiovascular disease.
Okay.
And a moderate decrease in the risk of having a heart attack. But it didn't significantly lower the risk of stroke or the need for those artery opening procedures. And there was a slight increase in the number of people who stopped taking their medication because of side effects or other reasons.
So lower isn't always better when it comes to LDL cholesterol.
That's an important point that the guideline really emphasizes, that when setting LDL-C targets, it's a shared decision between you and your doctor.
Right.
You have to consider the potential benefits, the potential harms, the costs of treatment, your personal preferences, and even things like access to care for different groups of people.
It's more complex than just getting the number as low as possible.
Much more complex.
And it sounds like there's still a lot we don't know about cholesterol management.
The guideline highlights several areas where more research is needed.
Like,
Well, for example, we need more data on how safe and effective PCSK9 inhibitors are in different populations and in older adults.
right.
And we need to figure out the best ways to manage lipids in people with type 1 diabetes.
Gotcha.
And we need more long-term data on inclisiran to see how it performs over time.
And what about those other areas we talked about, like pancreatitis and LDL targets?
Right, so there's still debate about what the ideal LDL-C targets should be.
Hmm.
And we need more data on the role of ApoB in predicting risk. We need more information on preventing problems with blood flow in the legs and on lowering triglycerides independently of other cholesterol-carrying particles.
So lots of ongoing research
You're
to help us fine-tune these recommendations.
Exactly. Science is always evolving.
So to wrap up our deep dive into these 2025 AACE guidelines on non-statin medications for high cholesterol,
Yes.
what's the main takeaway for our listeners today?
The main takeaway is that managing high cholesterol is complex,
It is.
and there's no one-size-fits-all approach.
So it's all about individualized care.
Exactly. We need to assess your individual risk factors,
Right.
weigh the potential benefits and harms of each treatment option,
And most importantly,
make decisions together, you and your doctor as a team.
couldn't agree more. And I think it's worth emphasizing again that while these medications can be really helpful,
They can be.
lifestyle changes are still absolutely crucial.
They're the foundation of good heart health.
So if you're listening to this and you have questions about your own cholesterol management,
Don't hesitate to talk to your doctor.
exactly, have an open and honest conversation with your healthcare provider.
They're there to help you navigate all of this.
And this deep dive has hopefully given you some good questions to ask.
I hope so.
Now, one final thought for our listeners to ponder.
Okay, hit me.
Given all this complexity and nuance we've discussed today, how do you think these guidelines might change as we get more data and as new treatments become available?
That's a great question to think about. The science is always moving forward, and our understanding of cholesterol management will continue to evolve.
So stay tuned.
Always.
Thanks for joining us for this deep dive.
My pleasure.
We'll see you next time.
See you then.
Bye.
Bye.